So my name is Karen Salva. I'm a pediatric endocrinologist and I practice in Portland, Oregon.
Hi, my name is Jess Guerrero. I'm a social worker with a second really nerdy degree in gender studies. And I'm the patient-facing social worker at OHSU's Transgender Health Program in Portland, Oregon. And about half of my work is dedicated to our pediatric Dornbecker Gender Clinic.
My name is Kara Connolly. I'm a pediatric endocrinologist and the medical director of the Dornbecker Gender Clinic. I practice at OHSU in Portland, Oregon.
I saw my first transgender patient in 2010, so it's been 10 years now.
So my journey in providing transgender healthcare started back in Boston at Fenway Community Health, where I interned and then worked as a per diem counselor very briefly before moving to Oregon. And most of my caseload at that time were 12 to 29-year-olds who were exploring their gender identity. And I was a 12 to 29-year-old exploring my gender identity.
I think it's probably been about 8 years.
As of December of 2019, we have touched base with and or seen over 640 patients since 2010. Right now in our practice, between the two of us, we would estimate that our trans kids are about a third of our patient population. And they can account that, diagnosis or that referral for transgender care is accounting anywhere between, I would say, 12 to 30% of the new referrals per month that we get.
Our clinic in 2019 saw nearly 500 unique patients. And so we've had a pretty steady growth over the last 5 to 8 years. And how many do I see personally? I don't know, a quarter of that maybe.
From the time that I was in high school, I thought that I wanted to be a counselor or social worker of some sort, but tried to run away from that multiple times and landed in a very theoretical degree program. And then I lost a friend to suicide, and he was a transgender man. And it was also at the time that my identity was really consolidating. And it was sort of a wake-up call to say, it's time to get out of the books and kind of back on the ground and take a look at individual practice and policy and systems that really impact the day-to-day life of transgender youth and young adults in particular, but gender diverse folks across the lifespan.
I've thought about that with that first patient. The child had type 1 diabetes. So when he presented to our mental health provider in our clinic, our social worker, for depression, everybody thought, oh, it's related to having type 1 diabetes because kids with chronic illness definitely struggle with depression. And he came out to her as transgender. I finished fellowship in 2003, and this is 2010, so 7 years out of fellowship. We weren't trained in transgender medicine, but the guidelines had just been released in 2009, so we were aware that this was a thing. And I think I was just like, well, this is something new and I'm open to doing it, and I'll do it. Soon after that, the Peds clinic called with another patient that they had seen, and they're like, we hear, someone said you might do this, and I'm like, yeah, send them our way. And then they were like, will you do grand rounds? And that's when I called you. And that's when it took off, was really from that grand rounds presentation we did.
I actually was not exposed to transgender healthcare at all in any part of my medical training, all throughout medical school, even my pediatrics residency. And it wasn't until I was a fellow and I was seeing patients in clinic, because back then, even though the Dornbecker Gender Clinic formally didn't exist, we were seeing a lot of transgender patients in our pediatric endocrinology clinic. And we were back then doing even more outreach clinic than we were doing now. And so I had the opportunity to see patients that had begun their care with some of our providers who were traveling far distances for outreach clinic. And then when those outreach clinics kind of were eliminated, the patients were needing to travel to Portland to get their care. I had the opportunity to meet a fabulous person named Jen Burleton from TransActive, who came and gave our group a presentation about the services that they were providing. And that kind of opened the world to me to recognize all of the activities that were going on around me or going on around us in Portland, and realizing that we really needed to do better at connecting with the community organizations and kind of streamlining our care better.
The first reality is that pubertal suppression, hormone therapy, surgeries are incredibly important to many, many people. And they're just a small piece of the pie in terms of what contributes to someone's overall health and well-being. And though we are a small team, we are a mighty team, but we just can't do it all. And so we do count on community partnerships and collaboration to make sure that this holistic view of health and well-being gets carried forward, and patients and families know where they can go and who they can contact.
I think one of the most important things is that I recognize that the community partners are on the front lines and we're in the lives of our patients. And I've really been able to get a better idea of what my patients are experiencing outside of the clinic setting by being able to collaborate with community partners.
Yes. We always try to get the parents on board. They were older, so we were not looking for pubertal suppression in these kids. And we were doing, hormone replacement therapy, which is honestly pretty cheap. Legacy has charity care. And so we just presented it to charity care, and that this is life-saving for this kid. And it's really not that expensive. Can't we just eat it? And we did.
We make every effort possible to bring at least one adult on board. That said, we know that waiting is not a neutral option. And so we're constantly helping the youth and sort of having a parallel process of weighing the distress of waiting versus the distress of estrangement from family, etc. Once someone is on a plan, the subscriber can't block the care, but if there's a financial responsibility and the youth doesn't have the ability to pay, then that gets tricky. And then again, we would worry about the safety piece, and if an EOB gets sent home, if that outs the kid, or if then that becomes the paper trail that the parent figures out that the kid's taking medication, then that might not be a great situation.
Ever since I started T-Clinic, I felt that, it is multidisciplinary. It was my nurses who were doing the intake, and I expected of them what was the work of someone with behavioral health background, and it was not in their wheelhouse.
I really feel like the behavioral health piece is most critically important for the family and for the parents, and that it's been a really interesting experience as we've dedicated more of our time and even some alone time separate from the youth in recognizing how much support the parents need from the behavioral health specialists. Once the clinic visit is over, we have recognized that there are a lot of needs that are ongoing, and that the families and youth really benefit from more points of contact before that next scheduled clinic visit. And that, I think, and anecdotally really improved the patient experience and their preparedness for coming when they came back to their clinic visit. I think it also helped to keep conversations going at home that may not have otherwise continued beyond the clinic room. And we were able to demonstrate that it did result in a higher percentage of patients that actually returned for their second visit.
The child was going into 6th grade, new middle school, and the parent asked me, and the kid was stealth, was one of those early transitioners, and the parents asked me, well, do we tell the principal? And I didn't know. I'm like, that's a question for TransActive. And I think they did reach out to you and get some advice. The other thing that I remember, the parent didn't want to call the school. It was a new school. I don't remember if they moved there, if the kid was moving up or whatever, but wanted to know, how do you handle transgender kids in your school without outing their child? And I asked you, and you said, have them contact me and I'll call the school. And I was like, that's brilliant. And I've said that to other families. You may have gotten other phone calls since, but I'm like, if you want to know and not have them know who the kid is, Jen can do the service for you. We refer to your support groups all the time. Parents really, really want support groups. They're the most talked about and I think appreciated support groups that I've heard, even from those tweens that are kind of angsty and don't really want to go, but the parents saying we're going, and then they get something out of it.
We're seeing a good number of youth and maybe more and more who do not want to claim to have the identity as transgender or gender diverse or gender nonconforming or anything other than cis. And most of the time, it doesn't get in the way of their accessing care, because they'll put up with going to the doctor and getting their prescriptions and getting their medications and everything because the end result is what they want. But I think occasionally it can get in the way of their accessing care, and almost to the point where they'll say, if I have to say that I'm transgender, then I'm just not going to do any of it. And we've had some kids beg to have every record of anything gender-related, surgical procedures, erased from their record forever. Mm-hmm. And to have an adult provider just prescribe their hormones and never talk about it ever again. So that's been a little bit of a challenge.
Be open to working with them. Take the time. I know that a lot of people think, I'm so busy and I just don't have time to do this. And I just get so much out of it. For me, it's just, it adds to my professional career and presence. And I think I'm a better doctor because of it.
I think the tricky part, and I feel this is where I feel super lucky to have Jess and Amy, is the time sometimes to have ongoing conversations, especially about individual patients. I think sometimes healthcare providers we have limited time, and our team members, Jess and Amy, can facilitate those conversations. And so some healthcare providers that don't have team members that can help to facilitate those conversations, that's where the tricky part can come in.
I think we're going to have to get creative in the new virtual worlds where there aren't necessarily the tabling opportunities or the conference presentations, or at least not in the same way. So thinking about what networking looks like when there's a pandemic going on, and being really strategic, and when we hear about one community partner or meet someone new, making sure that that person is sort of brought into the fold. I think sometimes what happens is there's a bit of a territorialism that happens. And yes, baby. And speaking of territorialism, and that we need to be collaborative more than anything right now.